bleeding and shock. You know, we did bleeding and shock last week in our labs, you know, just controlling bleeding. So tonight we're going to kind of get the background on that. Tomorrow night we're going to hit bleeding and shock again as part of one of the other stations. I can't remember which one. Oh, it's part of vital signs, I think. And so hopefully this lecture will give you some background on what we were learning. We're going to look at how to recognize the various types of bleeding. You're going to understand that a capillary bleed isn't nearly as severe as an arterial bleed. We're going to look at how to evaluate how bad it is, and then how to control the external bleeds. Now we're going to look, after that, we're going to try to identify the signs and symptoms that tells you that your patient is having a bad reaction from losing all of that blood, which would be shock. So we're going to look at the signs and symptoms of shock. A lot of stuff we've already been over, the circulatory system. If you look here, you can see that the blue are what? Veins, and the red are arteries. Yeah, that's right. What are the names of the arteries that we most commonly will come in contact with, I mean physically, but that are of interest to us? The carotid, the femoral, the brachial, radial, the pedal pulses, the dorsalis pedis, certainly. Those are probably the ones that we're going to encounter most in what we do, besides the aorta, which is what? The largest artery in the body, yeah. Okay, our arteries carry, typically, oxygen-rich blood away from the heart. Now these two, oxygen-rich blood and away from the heart, one of these is always true and one is almost always true. Away from the heart is always true. Remember that. You're trying to identify if it's an artery or a vein. If it moves away from the heart, it's an artery. If it moves towards the heart, it's a vein. So when specifically is it not oxygen enriched? Yeah, the pulmonary, that's right. When the artery is moving away from the heart to the lungs, it's going to be an artery. When it's moving from the lungs back to the heart, it's going to be a vein. That's right. Arteries are very large muscular vessels because they have a large amount of pressure that's moving through them, right? So they have to be very muscular and very strong. They vasoconstrict and dilate against that pressure frequently. Veins are just the opposite. They are typically oxygen depleted, but they move towards the heart. All veins move towards the heart. Now, one thing that differentiates veins from other vessels is they have those one-way valves. It has a little valve in there. What's the purpose of the valve? Prevent the blood from backflowing. Yeah, if you think about blood returning from your feet, having to go up your leg, and every time you get that pulse, you know, it pushes forward. Well, in between that pulse, if it didn't have that that valve, it would just drop right back down. So the valves are very important. And one way they prevent the backflow of blood. Capillaries are microscopic blood vessels. They're very small, like the size of a human hair or sometimes smaller. At the capillary beds, that really is where gas exchange occurs. You have oxygen that is offloaded to the cells, and then carbon dioxide and other waste products are picked up from the cells. So where else do we see these capillary, these capillary beds occur throughout the body, but one of the questions on your test was about internal and external respiration. So where are the capillary beds located where we have external respiration? In the alveoli, that's right.
So what was it?
What was what?
What was that question I asked you about? What was the answer?
It was external respiration.
I put in that.
Oh yeah,
I didn't do that.
Remember us talking about it?
I think we all missed that.
Really?
I thought it was
we all got it
pulmonary.
There wasn't a choice. You had to go with what the
That's
choices
why it
were.
confused me because I thought that was the answer.
External respiration occurs at the capillary beds in the alveoli because the air is coming directly in from the external, right? But then at the capillary beds throughout the body, then it occurs, they call that internal respiration because it's actually occurring like deep inside the body, if that helps you remember it. Well, you didn't have that choice.
Uh-huh.
Was that a
Yeah,
choice?
Yeah, it was a choice.
Well, I mean,
Maybe we can go back to that.
yeah, that is a
Fix it.
National Registry question. And so I want you to be familiar with it when you see it on National Registry. Internal respiration occurs at the capillary beds and the alveoli. External respiration. Internal respiration is going to occur in the capillary beds in the body. You know what the star means, right? Okay, it means get ready. I hope this is, yeah. I hope this is going to work for me. Arteries carry oxygenated blood. Holding open, that's a good sign. Everybody?
Are we on channel one?
One more. It doesn't
I
matter.
mean, channel 41?
One more. Yeah. One more. Who hadn't polled? She was. I'm going on without you. What's the answer I have out here? See? Not, some of you missed that. Arteries don't always carry oxygenated blood, because sometimes they don't.
So it's false?
Arteries carry oxygenated blood. I guess I should have phrased that better.
Yeah.
It's 'cause it is.
Yeah.
I should say arteries always carry oxygen.
Yeah, there you go.
You were
Okay.
trying to trick us.
My bad. Yeah, I guess I was. I just,
So I think
I
it's-
like to trick you.
I think
Makes
it's
me feel
testes
bad.
boogers.
Okay, let's look at what the blood does for us. It transports our gases, right? What are the gases that are transported? Oxygen and carbon dioxide are the main ones, yeah. Nutrition, it carries nutrients. What else does it carry? Waste products and maybe hormones and stuff. What? Yeah. Carries our antibodies, hormones, electrolytes. Yeah, so the blood is very important to us. It does a lot of good stuff for us besides just carry oxygen. So you saw the star on that next one, right? So that means you're ready to go.
Hold
Hold on,
on.
hold
Hold on
on.
1 second.
Back up, back up. I guess it's easier for you to just write it down now instead of have to go back and look it up online where it's sitting there waiting for you.
I like doing it right here.
What about all your buds here? They're going, gee, really?
That'll be all
They'll be, y'all will survive.
Yeah.
right. All right, I'm good now.
Most of 99% or 95% of the stuff's in your book anyway. Okay, y'all ready? Adequate blood flow to and removal of waste products from the cells. One more. Who's not playing? There are 13 of us here, aren't there?
My controller keeps turning off, so it might be me, but I don't.
You have to turn these things on?
Oh, you don't?
No.
Oh, so.
Oh, so. 41.
Hold on, let me see it.
Who's not playing? Oh, see?
Oh, it was
Who's the
me.
last one?
Me, I kept clicking.
We must have hit it at the same time.
Okay. Adequate blood flow. Whoever picked hypoperfusion, adequate blood flow and removal of waste products is perfusion. That's right. The result of inadequate blood flow and removal of waste products is what? Shock. The result of hypoperfusion is shock.
Mm.
Okay. Here we go. Adequate circulation of blood through the body. Inadequate circulation is hypoperfusion, which will lead to shock. Sometimes they'll use those phrases interchangeably, but do know that hypoperfusion leads to shock. Okay, I got a question for you again. What is the role of the respiratory system relative to the circulatory system?
To bring in
Breathing.
So the respiratory system is going to bring in oxygen, right,
And then circulate.
and gas off carbon dioxide. What's the relationship to the circulatory system?
It sends it throughout the body.
Well, yep, circulatory's got to carry it around. So you can have movement of air in and out of the lungs through ventilation, but you got to have the circulatory system in there, right? Delivers oxygen to the blood to supply the body. So they are definitely interrelated here. Okay, let's look at bleeding. Internal bleeding, external bleeding, right? Okay, I think we got a question, or else I think I might have something else on here. The capillary blood. Hey, y'all really didn't think about that. See, now we'll see who actually read the chapter and who didn't. 11, 12, that last person, who's the holdout? Wait on it, somebody's not playing. Hey, wait, where's the right answer?
I know what it is.
The right answer is C, oozes.
Dang.
Yep, it oozes. What flows? Venous blood. What spurts? Arterial.
The book says it plays as well.
It doesn't
Under
flow.
the picture. It says
So,
slow, even flow.
so capillary does not flow.
So what does it say about veins?
Steady, slow flow. Dark
That's
red
the
color.
picture, but in the text it says ooze.
Well,
Yeah,
the picture is
ooze, ooze really is what we're looking for. I'm not gonna count it wrong today, okay, Hillary? If you miss it on the test, that's something else.
I'm just stating what the book says in the wrong place.
Okay, here we have, capillary is slow, even, I don't know what all that means. But this is a oozy kind of thing. When do we see a capillary bleed commonly? Yeah, with, what? Road rash, a nosebleed often might be a capillary bleed. It could be a venous bleed. Arterial bleed, you're gonna recognize that one. That's no problemo. Capillary blood is slow and oozy. It's very easily controlled. Usually you can stop capillary bleeding within a matter of seconds. You know, you hold direct pressure on there for 10 seconds, it's done. Whereas venous is going to take a little bit longer, but it should be controlled easily, you know, under a minute.
With the venous?
Venous, yeah, usually about a minute. Whereas arterial bleed, you're probably going to have to hold pressure on an artery for probably 5 minutes for it to clot off. Why do you think it takes so much longer for an arterial bleed to clot off?
Directly from the heart, right?
Yep, that pressure is so great in there that every time that clot starts to form, that pressure in there kind of tries to dislodge it. So you're going to have to hold direct pressure on there for a while. You'll recognize arterial because it has that spurt thing going. You know, as long as the patient's heart is spurting.
And it's bright red, right?
It's usually, yeah, it's going to usually have a lighter color because it's oxygenated. The darker color is going to be deoxygenated. So which one of these is going to be the darkest?
The venous.
Which one's going to be the lightest? So what about capillary?
This will be in the middle.
Yeah, the capillary is kind of a middle ground there because you've got your oxygenated blood and your deoxygenated blood. That's the point of exchange is at the capillary beds. Good job. Let's see, how severe is, these are things you want to ask yourself, how severe is the bleeding? Because knowing that is going to set the priority for your patient. So if they have an arterial bleed, what's their priority? Yeah, that's probably pretty high. Capillary bleed? Don't bother me. Please tell me you didn't call for a capillary bleed. What you would also want to know if your patient has an exsanguinating bleed. You know what that is? I have that on there because it's a registry word. Exsanguination. Anybody got that one? Oh, it may not be any good. I'm just testing it. Exsanguination is going to be a total bleed out. You really lose all the blood in your body. It's exsanguination. It's gone. You just bleed them out. Yeah, if you get a carotid artery severed, they're going to just totally bleed out. Probably in about a minute or more, a minute or two. So you're looking to see if you think your patient may bleed to death. And that's one of the things we're looking at when we decide if we're going to put on a tourniquet. If they have an arterial bleed and it's squirting and they're losing a lot of blood, they run a risk of an exsanguinating hemorrhage. In that event, you would want to put on your
Is that if you can't
tourniquet.
stop it? Like
Yeah,
you
if you
yourself
can't-
can't stop the artery from
Yeah, if you
bleeding?
can't stop it, you're putting on a tourniquet, yeah. If you can't stop it, they're going to bleed to death.
Except for on the front.
Can you just get
Except what?
Except for
Yeah, and the
Get some
carotid,
trauma.
we're probably not gonna put that tourniquet on.
Well, they're not bleeding anymore. You're not bleeding either.
Yeah. Okay, now we're gonna get to our patient assessment of a patient that's bleeding. The top of the list, the little purple up here says what? Yeah, you're gonna have your BSI on as a minimum. If there's a lot of blood, I'm probably gonna put on a lot more BSI. Now, this is the only time where you may consider jumping over airway and going right to circulation. If they have an arterial bleed and they're squirting blood all over, you better immediately put your hand on there and get something on there as quick as possible. Now, if you've got your hand on there, it's going to slow it considerably, but you want to get a 4x4 or something on there pretty darn quick. But while you're doing that, if you've got a partner or if you're just able to grab that, then you can immediately start checking their airway. Are they talking to you? Are they breathing? That kind of thing. If they're not breathing, you're going to have to ventilate, have somebody ventilate, because you control the bleeding, but they're not breathing, you haven't done them any good. So you're still going to go through your ABCs on that. But if they're bleeding, they're squirting it somewhere, then you want to put a gloved hand on there immediately until somebody can get there and put something on it. Then you're going to start to work on the airway. Okay, y'all ready? All right. When should you use a hemostatic dressing? It was in your book. Did y'all talk about hemostatic dressings and bleeding shock last week? Okay. Okay, only half of you's voted. You're cracking here. This is not a test. Oh, good work. Before the tourniquet. Ah, wait, where's my answer? What'd your textbook say?
I had it at A, but then I switched to C.
A, C. Oh no, it's after direct pressure. Probably before a tourniquet. I can't remember the answer right now. Where's my answer?
Is that what the clotting stuff is called?
Yep.
It's,
What is it
I
called?
didn't know what it was. I
Yeah,
didn't know.
hemostatic.
It's before.
Hemostatic dressing, yeah.
And that's clotting?
Yeah, some type of clotting agent on it. Now, they used to emphasize elevating, direct pressure and elevation. We still do elevation because it just kind of helps slow that down. The body's having to pump uphill. So you put on the direct pressure and elevate it if you can. If it continues to bleed, like if you put your hand on there and the bleeding is slowing down, you're not seeing any more oozing, I'm going to stick with that. I might put a couple more bandages on there, dressings on there. But if it continues to like squirt all over in here, then I'm going to put a tourniquet on there. Now, pressure dressing would be, if I was holding like this and I put a few more dressings on there, if I wrap that very tightly to maintain some direct pressure. That's what a pressure dressing is. Direct pressure, apply firm pressure to the wound with a gloved hand and a gauze bandage. So as soon as you can get a bandage of some sort on there, a 4x4 or whatever you've got, you want to do that. And then, as we mentioned before, don't pull that off and put fresh ones on. Just keep putting new ones on top because you don't want to disrupt that clot. As we said, the arterial bleed is going to take you several minutes to control that bleeding. So I'd give it some time. As long as the bleeding is slowing, and I see that I may stand a real good chance of stopping that bleeding, I'm going to stick with it before I put on the tourniquet. Hold pressure until bleeding is controlled. Add new dressings over the other ones as they become saturated. Don't remove the bandages. Why not? I already told you. Clots, yeah, you don't want to disrupt the clot. Now, once you control the bleeding, still go and check for distal pulse. What exactly does that mean, a distal pulse? The pulse is going to be further away from the injury. So like if I've got the injury right here, what's my distal pulse? It's going to be my radial, that's right. You want to consider elevating the injury above the level of the heart if possible. Now if you've got a musculoskeletal injury, like somebody that fell off a bike and they've got a broken arm or something in here, then you may not wanna do the elevation thing or elevating the leg. You don't wanna make it any worse. Just put some direct pressure on there. Oh, where's my little star? Okay, my bad. We have a question coming up. How does elevation slow bleeding? Okay, a couple more. Okay. Ta-da! Good job. I wonder if I have a little arrow in there. Oh, no arrow. You're right, gravity. Pressure dressing, just where you put several gauze pads on there and then wrap it to hold it in place. They have some really neat self-adhering wraps now. Have you seen those?
Oh, yes.
They're great. Yeah, they're nice. Create enough pressure to control the bleeding. Talked about hemostatic agents. They have different substances. There's several different kinds. Some work better than others. I like this kind because you can just put it right on there, and it helps to, it brings their red blood cells together and hopefully release some platelets so that you can get a thing going on there. Can be wadded up and inserted into the wound if it's a real deep wound. They have some that kind of rolls off like you pull those little cling wipes out. And you can bring that out and you can actually stuff it down in the wound. And that's not something we're going to take out. Those people are going to surgery, and it'll be removed there where they can stop the bleeding. But you'll still need to maintain manual pressure on there.
After you insert it?
Yeah, you're probably not going to be doing any insertion ones. And they even have some that has like some powdery material that you can put in there. You're going to use whatever your medical director has approved for you to put on your ambulance. And they'll show you how to do it too. Tourniquet, if you can't control the bleeding with direct pressure and elevation, then you'll put on a tourniquet. Use only on extremities. Don't put it on the neck. It's never a good idea. Alright, got a little star here, that's a good sign. What can be substituted for a commercial tourniquet? Let's see if you read the book. Couple more, come on now. One more, take a guess.
What is a cravat?
A cravat, we're going to be looking at how to put on a sling and swab later. It's just a triangle bandage that's folded down.
Oh.
So, good work. BP cuff. I think the answer's going to come up. Yeah, BP cuff. What is the criteria for a tourniquet?
Pressure.
Well, it's got to maintain pressure. How wide is it supposed to be? It's got to be at least larger than 2 inches, I think. Your book said 4 inches. I think it's 2 inches.
What is a BP cuff?
Blood pressure cuff.
Oh.
Sorry.
That's what they use in surgery all the time.
Blood pressure cuff.
That's one.
Yeah, because they're wide and they can just pump it up. That's all we're doing when we put a blood pressure cuff on. We're putting on a tourniquet. And when we're listening, we're pumping that up. When we can't hear it anymore, it's a tourniquet. Then when we release it and we can hear that, the blood's flowing, and it's no longer an effective tourniquet. Does that make sense? Yeah.
The book says that B could also be a correct answer.
I'm sorry?
The book says that B could also be a correct answer.
Well, I don't like that one.
I mean, I chose C, but I'm just saying.
Well, if you use a cravat, you got to make sure that it's wide enough to be used. The blood pressure cuff is the best answer. And that's something, I might have put this in here to make this specific point. On National Registry, you're going to have to select the best answer. Always the best answer. So if you've got two, you go, yeah, one of them's going to be the better answer between the two, and you're going to select the better answer. The one that's like always true. Sometimes, like we were talking about arteries back there, you know, the blood flow, oxygen or deoxygenated, a choice like that, if there's one that's always true and the other one is almost always true, you're going to go with the one that's always true. So in this case, blood pressure cuff is the better of the two answers. Could you use a cravat? Yeah, provided, the thing with about a cravat, you can make them very slender or very wide. So it would only be useful if you had it very wide, because it has to be at least 2 inches. Good, that was a good question. Tourniquet, once applied, you don't take it off. You leave it on. You want to make sure that you put some type of notation so that you alert the people at the emergency department that you've got that tourniquet on, and when you put it on, and where you put it. If you've got a mass casualty and you've got a lot of injured victims, and you put a tourniquet on somebody's lower leg, and now they're covered up with blankets and stuff, and they roll into the ER, you know, if they can get to that tourniquet in time, they may be able to restore blood flow and save the limb. If not, if it sits on there for 6 or 8 hours because nobody realized it was on there, then that part's pretty well gone. So make sure that you note it. I've seen it before when they write it, you know, tourniquet left, you know, ankle or whatever. That sounds stupid, but you want to make sure you put the time on there also, where it is, as well as what time you put it on there. Mentioned blood pressure cuff is a good tourniquet. One of the things you want to ask yourself, if you've got a patient that's bleeding, is if whatever you're doing, is it working? If it's not working, then you may have to step up. I think probably the most difficult thing for you is going to make that decision when I'm going to put a tourniquet on. There's a good chance once you put that tourniquet on, they're going to lose that limb. So you're kind of weighing, are they going to bleed to death? You know, are they losing so much blood? And I'm not just talking about, are they going to exsanguinate? No. If they lose, you know, 3 or 4 pints, they may go into irreversible shock. You know, if they've got a lot of other things going on, they're just that, more than just that bleeding, excuse me, you're going to have to make that decision about when you're going to step in and do that. You need to move on to a more aggressive step. That's your question. Sorry. Other ways to stop bleeding? Splinting. How does splinting help control bleeding? It does what? Keeps it from moving. Anything specifically besides it? What is it? Yeah, if you've got broken bone ends in there, bones bleed. They're quite vascular. And if you've got broken bones in there, then they may continue to bleed. By splinting it, it's not moving anymore. And just that motion, say you've got internal bleeding, and you continue to move that, and it may continue to bleed because you're setting clots internally too. And if you're moving that and breaking those clots up, then you run a risk that they'll continue to bleed. So splinting is a great way to control bleeding. Putting cold on there. You'll ever put a cold pack on your body and you know you're going to bruise? You've had some surgery, put a cold pack on there. Yeah, cold application. And you should have cold packs on the ambulance. There's one other thing called a pneumatic anti-shock garment, PASG. There's another word also, another mnemonic, which is MAST. MAST stands for Military Anti-Shock Trousers. PASG is pneumatic anti-shock garment. And if you see this lower part down here, this is the MAST trousers here. And they will fit up over the body kind of like big pants that blow up. And it provides pressure all the way around the legs, both legs, and even around the hips and the pelvis to put pressure on there. Military anti-shock trousers. That's where they came from, for the military. Now, we don't carry these on the ambulances in Alabama anymore, to my knowledge. We used to use them a lot, but they're still on National Registry. Some services, some states still use them. They're used primarily now for bilateral femur fractures. If you've got fractures of both legs, or you may use them for hip fractures, just for stabilization. We don't use them really for controlling bleeding so much anymore. But it is on National Registry, you may see it. So your textbook should detail when they're contraindicated. Let me see if I got it on here next. No. You wouldn't use these for a pregnant woman or a person with chest trauma because it forces blood up from the lower extremities up into the core. So if you've got chest trauma, you know, where you're bleeding internally, you don't want to force all of your blood up there. If they're pregnant, you don't want to, you know, inflate that the abdominal panel. But we'll look at these at one point during the semester so you can get a feel for them and see what they look like. You can see over here they're just splinting that to help control that bleeding. Why does applying cold packs to the wound help control bleeding? It causes blood vessel constriction. Exactly right. What happens to your body when you get really cold? Constriction. Yep. I got a couple things on here before we go, I think. Head injuries. If you've got a patient that's bleeding from the head, you want to note if part of that is from the nose or the ears. If you've got any clear fluids or what looks like blood mixed with some type of clear fluid, you know, where the blood looks like it's kind of watered down, then that may be mixing with blood but coming through with cerebral spinal fluid. So you don't want to, like if it's from the nose or the ears, you don't want to pack anything in there. You want that to flow freely. If you have blood anywhere else, you want to be concerned about, well, let me back up. I'm losing my mind. Nose and ears, if you got blood from those areas, it's probably due to a skull fracture brought about the bleeding because of intracranial pressure inside the head.
Is that severe bleeding? Or just like if you have just a nosebleed, you don't want to even like stop it?
Yeah, if it's a nosebleed from a blow to the face, that's different than nosebleed from a head injury.
Okay, I see what you're saying.
Yeah. We'll talk about this a lot more when we get to the head injury part, because there's a whole lot more to that. If you try to stop the bleeding that's coming from the nose or the ears, then you may actually increase the intracranial pressure, because that needs to flow to get out of there so the brain doesn't continue to swell. All right, y'all ready? Medical word for nosebleed. Let's see who read the book. Come on. Come on, come on, come on. All right. Oh, pretty good. I noticed everybody kept away from exsanguination. That was good. Thanks for that. Hemorrhage is any kind of bleeding, whereas specifically nosebleed is epistaxis, and that's a word you need to know, so make sure you jot that down because you'll see that again. Epistaxis. Just the old nosebleed. Ta-da! See, sometimes my error works. Okay. If you have a patient with a nosebleed or epistaxis, how do we control that? Stick a little like cotton up the nose? I've seen that. It always makes me laugh. Mash on their nose?
Tilt their head back?
Oh, always, yeah. Tilt your head back. What's going to happen then?
It goes down your throat.
They're going to swallow it, right? It starts. What happens when you swallow blood?
You can enunciate it.
Yeah, the bad thing. Yeah, you want to avoid getting blood in the stomach. It makes you throw up. So you want the patient to lean forward so it's going to drip this way, and then just pinch the nostrils. Most regular epistaxis is just a capillary bleed within the nose here. You may get a little venous bleed up a little bit higher, but you're going to stop it just by pinching the nose and having them lean forward. You want to avoid that swallowing of blood. You may consider, ice pack over the bridge of the nose. But yeah, you don't want them to put their head back and swallow that.
I always try to blow out as much as I had a lot of nosebleeds in wrestling. We try to get out as much as you can to at least stuff those things up and try to finish the match before they say you got to stop if you're bleeding too much.
Yeah, well, yeah, if you're losing a whole lot of blood, and you may actually encounter some elderly patients or patients with very high blood pressure, where it doesn't matter what you do, it's gonna continue to bleed, and they have to go in and cauterize that. It's pretty nasty. So anytime you've got an older person, an adult person with a nosebleed and it's not from trauma, you want to consider hypertension as a possibility. All right, if the patient becomes unconscious, put them in the recovery position, right? Why?
So we'll come out.
Yeah, so it'll flow out, so they won't aspirate, so they won't swallow it. Let's see, internal bleeding. A nosebleed would be external bleeding, right? You can see it. Internal bleeding is going to be bleeding that you can't see. Usually it's going to be due to, oftentimes from trauma, but it may not be from trauma. But a person can lose a whole lot of blood internally. We've got some very vascular organs, particularly around the torso and the abdomen. You can lose a lot of blood in a very short amount of time. But it's difficult to see because we don't see bleeding, right? If it's internal, we're not going to see blood. I've got one more. Severe blood loss can even result from injuries to extremities. Does that sound like external bleeding?
It says it right now.
Yeah,
Sure.
say, with the leg is an extremity, right? If you have a broken femur, you can lose 1 liter of blood per femur. That's a lot of blood. A lot of blood, yeah. So internally, that's one thing you'll notice about a broken femur is once it starts to bleed, the thigh can get so large and so hard, it's shocking the amount of blood in there. When we go down to the lab, I'll show you a 1 liter bag where you can see how much fluid that is. And if you pack 1 on each thigh, you'd be shocked at how big that could be. All right, got a star here, ready? Which indicate possible internal bleeding? Internal. One more. All right, let's see. Pretty darn good. Now, nosebleed indicates external bleeding pretty much to me, right? Pretty much. Signs of shock? Yeah, if you've got a patient and you don't have any external bleeding and you've got signs of shock, there's a real good chance that you've got internal bleeding going on. Arterial bleed would be exterior. A headache could indicate internal bleeding, but not in the way, usually when we talk about internal bleeding, we're talking about something below the neck, different than bleeding in the head.
What happens if they have like a severe internal bleeding in their head?
Then they may have a headache.
Like a bad headache?
Yeah, the worst headache they've ever had in their life. Yeah, here, headache could be an answer. Somebody with a head injury could have a severe headache. But signs of shock, if they got signs of shock, you're going to think internal bleeding. The leading cause of internal bleeding, blunt trauma. Blunt trauma is the leading cause of internal bleeding. What would be an example of blunt trauma?
Baseball bat in the gut.
The old baseball bat, yeah. A car wreck, you hit the steering wheel, something of that sort. Fall over the bicycle, you know, get a little kid that hits the handlebars. Falls, motor vehicle crashes, pedestrian accidents. You know, if you get hit by a car, you run a great risk of internal bleeding, blunt trauma. Blast injuries, we don't really talk about those very much. Now, blunt trauma, when blunt trauma happens, usually the skin is not broken. And you can have a severe injury under the skin. You usually see a lot of contusions and stuff. But usually the skin is not broken. Whereas penetrating trauma, something has actually gone in. Anybody know the difference between penetrating and perforating?
One's going in, one's
I
going
think
out.
so. Do what?
One's going in, the other one's going out.
Well, penetrating trauma, it goes in. Perforating, it goes in and out. Like if you're stabbed and it comes out the other side, then it's perforating. Penetrating, it just goes in. Like if you get shot through and through with a gunshot, that would be a perforating. Common penetrating injuries, of course, gunshot wounds, stabs. Which one of those would this be?
It's impaled.
The impaled object, yeah. Pretty cool. I don't know how that
Yeah,
happened.
that was supposed to do with my, and what it was.
Big splinter.
That was my one ER trip was
Was that-
tail.
Oh, yeah? What did you impale? What impaled you?
The D-ring off a dog collar. Ran over the llama, ran over right in the foot.
Really?
A what?
Like you hook the leash to the dog collar with a little metal D-ring. That was cool.
Wow.
That was lots of fun.
Yeah. I mean, people get impaled by some
But I
pretty...
saw a hook and a guy with it the other day, and I felt something.
Oh, yeah?
Like one of those big fishing hooks in his throat.
Oh, yeah. I worked at the beach for a long time. We saw lots of those. It's like, you did what? Signs of internal bleeding. The way that you'll recognize internal bleeding, oftentimes there'll be signs on the surface of the body. What would you be looking for? Bruises, yeah. Also known as the C word?
Contusions.
Contusions. Good work. Bruising, swelling, or pain over vital organs. Why, what's the deal with the vital organs thing here? Yeah. Any specifically you can think of, we definitely don't want to bruise up. Like your spleen in particular, I always hate for that thing to get injured up. Yeah, any of your vital organs, your heart, I hate it when it bleeds inside. Yeah, if they got pain, you know, when you're palpating, they're painful areas, or you notice bruising or swelling, DCAT, BTLS, you're going to consider internal bleeding. Any painful or deformed extremities, you know, a twisted ankle. You can have a broken bone that doesn't pop through the skin where it's like a closed injury. You can have significant bleeding. How many of you guys have like broken your hands, your feet, your ankles? That's it? Just a couple of you? Broken bones, come on.
So you can
Only
break,
the women?
you can break your ankle and have internal bleeding?
I've had that
Oh,
one thing.
sure. Because think about your ankle, you've got a lot of bones in there, and bones are very vascular. What happens inside the bones anyway?
That's where,
Specifically.
red blood cells are.
That's where our red blood cells are made, exactly. So you break a bone, they're going to bleed quite a bit. Bleeding from the mouth, the rectum, or the vagina, those might indicate internal bleeding somewhere. I think that's the last one. Y'all ready? Yep. Which indicates new blood. Come on, y'all. Get with it. This is not a test like I'm going to grade you and stuff. Come on, couple more. Wake up, somebody. Who's not awake? Take your names. Okay. Man, tough. Bright red. Dark and grainy. Maroon. Surprised to me you guys missed this. It's bright red. If you see, like, for instance, a rectal bleed, which we get, unfortunately, a fair amount of those, rectal bleed or GI bleed, very commonly, it's very dark and grainy. It looks like coffee grounds. That's old blood. It's taken a long time to work its way out. And so as it starts to deteriorate, it gets dark and gets very smelly. Bright red indicates it's fresh blood. You've seen blood that's like congealed and been laying around for a while. It gets very dark and nasty looking, doesn't it? So yeah. Other signs of internal bleeding, if you're palpating the abdomen, if they're losing a lot of blood in the abdomen, it's usually going to feel very firm. Distended. Distended means it's like bigger than it should be. It may be tender when you palpate it, but rigid is a dead giveaway. Because even somebody that's in really good shape, if they're relaxed and you're palpating the abdomen, it shouldn't feel like six-pack abs. Is that what it is? Yeah. But if it does feel like that, you know, it's some little old lady and she feels like she's got six-pack abs in here, it's because she's got some internal bleeding. If they vomit coffee ground or bright red material. So what do we know about the coffee ground looking stuff? Old blood. Bright red, new blood. Both are bad. All right, with kids, Remember, I've said this 100 times before because I want you to remember it. They can compensate very, very long. They can lose almost half of their circulating blood volume before they become symptomatic. You see what I'm saying? They can lose almost half of their blood and maintain their blood pressure. That's why we don't take blood pressure on kids under 3, because it doesn't matter. They could have lost half their circulating blood volume and they maintain their blood pressure. They're extremely efficient. So just because they look good, their blood pressure's good, that doesn't necessarily mean they are good. What are you looking at? The phrase starts with the M. Mechanism of injury, exactly right. If the mechanism is there, you go with it, whether the kid presents like that or not. You can take that to the bank. Potential for shock must be recognized and treated before telltale signs appear. Once they become symptomatic, remember I drew the graph for you? Looks like your brain on drugs. Here's a kid. That was about to be really bad. Y'all are going to let me do that. Okay, here's a child. I'm writing this on here so that y'all go back and view this later. Here's your child. Compensate, compensate, compensate. What happens? Sure. Yeah. Whereas the adult, they go, it doesn't look like much of an A, does it? They kind of go. How about that? So with that kid, here's what you're concerned about. If they've got mechanism of injury, you want to treat them here. You don't want to catch them here, because here it's too late. They have fallen off that cliff. You don't have your little nails in them, you're not going to get them. Cultural considerations. Sometimes you may have dark-skinned patients that are more difficult. You might think they're more difficult to assess their skin color. But if you've done this for a while, you'll notice that even very dark people, you can look at them and they look ashen. I know that's shocking. Does that surprise you? You can look at them, and just because they're dark skinned, that doesn't mean you can't tell that they're pale, because they are. But you can look at some other areas. You can pull down the lips, right in here. You can pull down the eyes and look in here, the bottoms of their feet, their hands. Those will look very pale if they're lost a lot of blood. They're real pale. But I would look in the mouth and the eyes first. Fingernails. What do we check with fingernails? Yeah, check a capillary refill. See what they look like. The conjunctiva, said that one. Palms of the hands, soles of the feet. Anywhere that the epidermis is very thin, that's what we're looking for. Okay, treatment of internal bleeding. Can we stop the bleeding? No, we can't stop that bleeding. But there are things that we will want to do to treat them. Number one is always going to be oxygen. If they've lost a lot of blood, then they're not circulating that much. Everything that does circulate needs to have as much oxygen as possible on it. Of course, you're going to maintain their ABCs, and then control any external bleeding. You're going to treat these patients for shock. Internal bleeding just like you would external bleeding, right? Because they've still lost that blood. And what does blood do for you? Circulates oxygen, and it keeps you warm. So if you've lost blood, even in your body, but it's out of the circulatory system, you can't stay warm and you can't deliver oxygen to the cells. So either way, you're going to treat them the same. So we give them oxygen. What else do we do? Keep them warm, yeah. We position them. We don't want them walking out to the ambulance, slinging blood as they go. You want to put them on the stretcher. Go ahead and position them. Transport them rapidly. Once shock gets a strong foothold in there, your patient dies, especially your kids. Y'all doing okay? You want to keep rolling here for a minute?
We're almost done.
We are? Okay. Shock. Shock is something you see a lot of in our business. So it's important that you understand A, B, C, and shock. Those are all intertwined. With shock, your cells are not able to, you don't have enough red blood cells to circulate oxygen. That's bad. It also, you don't have enough blood to remove the waste products. So there are two parts of that. It's not just one, it's both parts. Failure of any component of the circulatory system can cause shock. Remember we talked about the pipes and the pumps and the fluid, all those things work together. The absence or a problem with any one of those can cause your patient to be in shock. Now there are a few forms of shock that I want you to know. Cardiogenic, you can work this one out. Cardiogenic, cardio is heart. So if the heart's not working right, it's not pumping right, the heart loses its ability to pump, you'll go into cardiogenic shock. This just identifies the cause of the shock. With neurogenic shock, neuro means what?
Brain.
It's a nervous system, that's right. The nervous system, the brain, is not able to constrict or dilate. It loses muscle tone, muscle control over the vascular system. So what happens, I think we talked about this once before, it's not just it dilates, it loses muscle tone and it becomes flaccid. You know, so regular, you might be dilated and you might be constricted. Dilated might be like this. When it loses muscle tone, it just turns to mush, and it's not able to maintain anything. The vessel is much too large for the volume that's in there. If you're totally vasodilated, you might be able to manage 7 liters of blood. When you lose your muscle tone, it might take 15 liters to fill that because it's just totally flaccid. So you can't maintain your blood pressure. That's neurogenic shock, and it comes from the brain. It may be due to a spinal injury, most commonly due to a spinal injury, where the message is not able to get down past where the injured area is, and so it doesn't just vasodilate, it loses muscle tone. You can have a loss of blood if you've got hypovolemic shock. Hypo means low. VOL, that sounds like volume, right? So you have low circulating blood volume. So the pump doesn't work, don't have enough fluid, and what's the last one here? What would neurogenic be? The pipes. The pipes are not able to, they're not patent anymore. Okay, so we got 3 types of shock. We got cardiogenic, neurogenic, hypovolemic. Those are the main ones we're going to talk about. Later on, we're going to talk about anaphylactic shock. We may pick up a couple more, but these are our main ones that everything else comes off of. Okay, next we've got how severe shock is. And we've kind of talked about this, recognizing when your patient moves through the different stages. You've got compensated, decompensated, and irreversible. With compensated shock, the body's still working, it's still getting it done. It's not going to get it done forever, but for that period of time, it's compensating. What would be signs that your patient is in compensated shock, vital sign-wise? Okay, you just run up the steps from down in the basement there. You run up here, right? So you're compensating for a lot of work on your body. What happens to your vital signs?
Pulse goes up,
Your pulse goes up, respiratory rate goes up. What's your mental status like?
kind of,
From running up from downstairs? You're the iffy?
You're what?
you're slow to,
Well, if you just run up from downstairs, your mental status is probably pretty good. You know, you're not forgetting who you are or anything like that. So with compensated, your vital signs may be a little bit out of whack because your body's working to keep your blood pressure up. So your blood pressure is still good. Your pulse may be a little high, your respiratory rate may be a little high, but it's keeping your blood pressure up and it's keeping your brain perfused. You haven't lost your mental status. Decompensated, the blood pressure starts to fall. Now see what's happening now is the body's not able to keep up. It becomes tachycardic, increases the respiratory rate, but it's not good enough to maintain the blood pressure. Blood pressure and mental status is really what we're looking for here. So decompensated, the blood pressure starts to drop and you start getting an altered mental status. By irreversible, now nothing you do can save your patient. They may actually lay in this state for several days before they die, but they've had end organ damage. They've got cellular damage. They've got a lot of cell death. It's irreversible. And this also is It's going to be just like we showed you a few minutes ago. Compensated, you're like this. Decompensated, you're going down. Here, you're like this. So compensated, the body is maintaining its own. Here, it's going downhill, but you can still catch it if you treat it in time. Here, it's too late. I love this sport. Questions about that? So like if I give you a set of vital signs, say, that's a good one, we do that. Say your patient started out at blood pressure of 130 over 90 and the pulse was 110. Is that good or bad? Yeah, we don't really know. I mean, this is not blood pressure falls, really, unless we started out, say we started out at 160, you know, over 100, and now we're this. Either he's getting better or he's getting worse, right? If your next one is 108 over 70, is this still good? You see it going down, so you can't take anything out, you can't isolate any one of these. You have to look at the trend there. Now, if your patient's compensating, yeah, okay. Come on. Okay, what's the deal here? All right, stubborn thing. Say, if you're compensating, then you might see might be compensated. It doesn't really change much because he's tachycardic, probably, might have a pulse of 118. And that's what it takes to keep a good blood pressure. It's just not like... Good work. So you're going to look at the vital signs, and we're going to do some exercises with this a little bit later, not tonight, so you can recognize compensated and decompensated. This is just a graph of how it works. And it goes this way. So here the pulse goes up because it's got to maintain cardiac output, which is what? How do we recognize cardiac output? Blood pressure? Yeah, blood pressure is a result of cardiac output. If we got decreasing cardiac output, what's happening to our blood pressure? Yeah. So the pulse is going to increase or maintain cardiac output. And so part of what happens here is to keep the blood pressure up, you vasoconstrict, right? So your patients that are compensated, they're probably going to be cool, you know, pale, because they're vasoconstricted. They get clammy. Their respirations increase. Start shunting blood away from those unnecessary organs. Like the last thing the body really needs to worry about is digestion. That's why oftentimes when your patient's in shock, they feel nauseated because they got their dinner just sitting there. Digestion has come to a screeching halt. So it makes them feel nauseated with what all's going on in there. So that's why you commonly see nausea and vomiting associated with shock. So he'll say he's nauseated and that kind of stuff. Once the blood pressure starts to drop, then you're in decompensated shock. And then if you don't catch it right then you're looking at irreversible shock. Uncontrolled shock leads to death. So a lot of factors go into how bad your patient is and their level of shock. If you've got an old person with several things going on, you know, they've got peripheral vascular disease, they've got asthma, you know, they've got who knows what, and then they fall down some steps and get a traumatic injury, they're going to be much worse off, and they're going to get to decompensated and irreversible shock much quicker than one of you guys that just fell down the steps. Types of shock, we mentioned these: hypovolemic, cardiogenic, neurogenic. Oh, what happened to my thing? Okay, quiz. What is the loss of circulating blood volume? Come on, no sleeping. Somebody's always the last one. Loss of circulating blood volume. Hypo means low. VOL, volume, low volume. Loss of circulating blood volume. What is a cardiogenic shock? It's not a volume issue. It's the pump issue. It's not pumping right. Oh, that scared me. Hypovolemic shock results from decreased volume of circulating blood and plasma. If you haven't got an injury where you've lost blood, how else can you get hypovolemic shock? That would be some blood, if you hadn't lost any blood.
Brain injury?
Do what?
Brain injury?
You wouldn't have hypovolemic shock, low circulating blood volume. Dehydration, yeah, whoever said that. Yeah, but you circulating blood and plasma, so if you've lost a lot of that fluid in there because you've sweated it out, you've got a loss of circulating blood volume. Blood pressure drops, patient gets real dizzy, disoriented. Pretty soon they're unconscious, and it's just because they've lost fluid. Called hemorrhagic shock if it's uncontrolled bleeding. Hemorrhagic shock meaning it's blood loss from bleeding. It can be caused from burns. You can have hypovolemic shock from a burn because why? Dehydration, yeah. That fluid just evaporates right out. Crush injuries, that would be a hemorrhagic shock. Cardiogenic shock, we see this with patients who are having a heart attack very frequently. The pump ain't working anymore. Just can't pump. Results from inadequate perfusion to the heart, decreasing strength of contractions. That would be one thing. If the heart's not getting blood, it's not getting enough oxygen, then it's going to decrease its contractions also. It can be an electrical problem in the heart. Remember the 3 nodes we were talking about? What's the primary pacemaker of the heart? The SA node. What's the backup? The AB node. And the final one? The bundle of His through the Purkinje fibers. What is the default heart rate of the SA node? 60 to 100. What is the default rate for the AB node? 40 to 60. And the bundle of His? 20 to 40. Okay, just checking. Neurogenic shock, we talked about that. This is going to be a problem with the brain being unable to control the dilation of blood vessels. It can be caused due to nerve paralysis, which would come about with a spinal cord injury. This doesn't have any blood loss. It's a nervous issue. The vessels are so big, there's not enough blood volume. We don't see this very frequently in the field, unless it's an older injury. You know, it happens sometime, at least several hours before. Takes a while for that to occur. Signs and symptoms of shock. You'll recognize your patient going into shock, not just compensated shock. Decompensated shock is going to be altered mental status. One of the first things that you'll notice. Skin is cool, pale, and clammy. I mentioned nausea and vomiting because why? Why do they get nauseated? Shunting blood away from the stomach and digestion. You'll start to see changes in the vital signs. What will the blood pressure start doing? It's going to start dropping. That's right. Why does hypovolemic shock cause nausea? I already told you that one. Good for me. Care for shock. Same thing as controlling bleeding. You're going to have to aggressively manage the airway because they're not getting enough oxygen for whatever reason. If it's hypovolemic shock, cardiogenic shock, whatever. So you've got to get oxygen going. See if you can figure out the cause of the shock and intervene if possible. If it's bleeding, then you may control that bleeding. Sometimes you can't do anything about it. If in states that use the PASG, you may use that. We'll talk about that in lab some more. If your patient's got any injuries, you may splint, any suspected breaks, injuries. You want to prevent heat loss. That's very important. So you want to cover your patient up and keep them warm. Even if you're like sweating like a dog, you need to keep them warm because they're not able to warm themselves. There's something called the golden hour, which is nothing that's real scientific, but they find that patients have a better outcome if they've got a lot of blood loss. They have a better outcome the quicker they get to the emergency department, the quicker they get into surgery. Surgery is definitive care for blood loss. It's the only way they're going to be fixed. So a golden hour, that means from the time the injury occurs to the time they're in surgery. 60 minutes or less is going to give your patient the best chance of survival. So what that means to us is we've got about 10 minutes. You get on scene, you got to do your ABCs, make your transport decision, do your rapid trauma assessment, spinal immobilize them, and get on the road. Everything else will have to be done en route. If you've got a patient in shock, it's important that you calm them down because what happens if they're all stirred up and excited and scared? Yep, they're going to get real tachycardic. They're going to require more oxygen. They're going to burn more oxygen. And that you don't need. So you want to keep them calm. This is just the photos of putting on the mask trousers. These are little inflatable legs. You put them on, then you wrap them up. And then you've got this little yellow cord here is a pump. And you pump it up to a certain pressure. And it has a little gauge on there. Pumping them up, blah, blah, blah. Y'all have to read about that. We'll bring them out one day, but you're not going to use them here. I do have a star, though. That's a good time. How should you care for an amputated hand? Who read the book?
The hand or the person?
The hand. You're not going to place a person in cool water, are you? Place him on ice. Okay, let's see which book. Oh, place on ice. Okay, who's right here? I hope I have my little ticker going. Wrap in a dry dressing. This is one person. Who got it right? Okay. Why don't we want to place it on ice? Yeah, it freezes it. Yeah, it's already damaged, and now you're putting it on ice. It'll freeze it, damages the tissue. Yeah, you never want to put it on ice. Now, you might wrap it in a dry dressing and then put it in a baggie and then put it on ice, but only if it's wrapped up very well. So there's no direct contact with ice. Why would you not want to put it in water? Cool water?
It all grows.
Well,
Yeah, you put it in water, and what's going to happen with the blood that's remaining in there? It's going to flow right out, and now you've lost any blood that was left in there. It's been replaced with gush, water. We don't want to put it in a moist wrap either for the same thing. It'll draw that blood out of there. You don't want to do that. So you put it in a dry, steril's nice. Put it in a baggie.
You actually need to
Not too much.
I swear that I
They're wrong.
That's
So you
Yeah,
need-
you
great
you
to
wrap
So
it
if you
up.
put it in ice, you wrap it up, like in a
Yeah.
plastic baggie, or
Or you're going to do it more than just a baggie. You got to protect the skin because that ice is going to kill that tissue. So
wrap
it's
it
just
up
like
again.
if you ice your body, you don't put ice directly on there. Not for any length of time anyway. Yeah. So you want to wrap it well. I'm sorry?
What about organs? Like during surgery, do they put it on?
They don't put it no direct contact.
They got
'Cause it kills
packaging for
tissue.
that.
Yeah.
It's not just like ice cubes.
Okay. Oh, look where we are. Yippee, yippee. All external bleeding can be controlled. Most external bleeding can be controlled with direct pressure. If it doesn't work, then we'll consider a tourniquet. Emergency care for internal bleeding is going to be treatment for shock. You need to know that. Take that one to the bank. The only treatment we have for internal bleeding is going to be to treat them for shock, and it's going to be rapid transport. You got to recognize shock before it occurs. Restlessness, anxiety, those are early altered mental status issues. So if they start getting cranky and restless, that's one thing you'll notice with a patient who's been in a traumatic injury, you know, a car wreck or something like that, particularly a head injury. They start getting real anxious and cranky and combative, and then you start going, head injury, or it could be they've lost a lot of blood somewhere, internal or external. Rapid pulse, rapid respirations, those point you to compensated shock, right? If shock is uncontrolled, the blood pressure will start to fall. So, you know, it's a process. They don't all of a sudden go, now I'm in decompensated shock, I'm in irreversible shock. It's a process. So one kind of runs into the other. Signs and symptoms may not be evident early. Treat based on mechanism of injury. Big deal. Treat shock by making sure the airway is good, high flow oxygen, control bleeding, keep the patient warm. Recognition of shock. You've got to anticipate and look for that index of suspicion that they could go into shock. I can't tell you how many people have died because we have failed to recognize shock. They look like they're compensating, and then they fall off a cliff. So, external hemorrhage, direct pressure, elevation, tourniquet. Use a hemostatic agent if you have one, or consider it. Internal bleeding is going to be hard to diagnose. You're just going to have to look symptomatically. Shock develops if the heart fails. What kind of shock is that if the heart fails? Cardiogenic. Blood volume is lost. Hypovolemic. Blood vessels dilate. Loss of tone. Neurogenic shock. Good work. Signs of shock reflect the body's attempt at compensation. The significant treatment for shock patient is what? Early recognition. You've got to look for it, expect it, treat for it, get them transported. Okay. Is a patient with pale, cool skin, tachycardic, rapid, shallow respiration in shock or just under stress? How are you going to know the difference? Huh? Mental status is extremely important. If they're just under stress, now they may be agitated, they may be a little bit cranky, but if they're in shock, they're going to get worse. If it's just they're agitated or under stress, they should stay the same or get better. Once you calm them down, you give them oxygen, they get better. Their vital signs stabilize. But if they're going into shock, that's not going to happen. They're just going to continue to get worse, probably. All right, a patient's been involved in a motor vehicle collision. There is considerable damage to the vehicle. So right away, what are we thinking? The M word? Mechanism of injury. The steering column and wheel are badly deformed. The patient complains of a sore chest. You note no external bleeding. What are you guys going to do? Yeah, this is a rapid transport because of mechanism of injury. Vital signs. Pulse is 116. How do you feel about that? It's a little fast. Respiration is 20. Blood pressure 106 over 70. Does this sound normal or not normal? You think they're under stress? They just had a car wreck. I mean, would tachycardia be abnormal here? Probably
Blood
not.
pressure would be higher normally than higher pulse.
Depends on who it is. Blood pressure may not go up if it's just stress, if you normally have 98 or something. How would you proceed to assess and care for the patient? What would you do for them? Start off by treatment for shock, sure. You'll spinal mobilize. Was this a car wreck? Yeah. You're going to spinal mobilize, of course. You're going to treat them for shock. What's the body position going to be? Yeah, got them on the long spine board. Oxygen by what route? They're going to get a non-rebreather for sure. Get them in the ambulance. What else are you going to do for them? Certainly. Ta-da! Okay, we do have one more chapter, so y'all take a break. Come back about 8:15.